Thanks to the organizers. Just for an outline of my talk, I was going to talk a little bit about the utility of stress MRI. One kind of partial disclosure that I would have is that much of the stress MRI data, much like anything that we deal with in pediatrics when it comes to coronary artery disease, is taken from the adult literature. So there's a minor to major amount of extrapolation that's going to have to take place depending on what lesion you're talking about. We can discuss very briefly some of the pathophysiology of some of these ischemic lesions within pediatrics. I'll briefly review our experience that we've had with both forms of pharmacologic stress that we've performed, and then some of the lessons that we have learned here. So just as I was alluding to, in terms of stress MRI, one of the advantages is its accuracy. And so there's several trials that have been performed within adult literature in atherosclerotic coronary artery disease. One of the landmark trials was the CMARC trial, which was in 2012 in Lancet, which was compared to SPECT and showed that in single vessel and multi-vessel disease, the stress MRI with pharmacologic stress by adenosine performed better than SPECT in terms of sensitivity as well as negative predictive value. In terms of pediatrics, there's a handful of studies that have utilized stress MRI. I'll kind of just run through these briefly because they're all very similar in nature with a comparison in a select amount of these patients with either CT coronary angiography or invasive catheterization angiography. In this trial here, this was performed by Emanuela's group in Zurich, again around mid-50s patients, heterogeneous population. In this trial here that was recently done at GOS, or Great Ormond Street, again about mid-50 patient number, with heterogeneous pathophysiology there as well. This was one of the initial papers of dobutamine stress MRI. This was initially performed at Boston. A great deal of these patients initially were having just wall motion assessment, and then about halfway through the trial they started adding perfusion to the end. This only had one inducible wall motion abnormality that was found in this select study of 28 patients. And then in our own population, our initial work in using regadenosine, which I'll talk very briefly about as our pharmacologic stress agent. So just a little bit in terms of how we assess the utilization of the stress MRI. I will caution a little bit, this is taken from the FAME trial. This is in adult literature again, which is comparing coronary angiography with FFR. So if you consider FFR, which the adults do, as the reference standard, and you can debate what level of FFR you want. Initially, this was done at 0.8. I think I saw a slide today that was referencing kind of the more current value of 0.76. This is really just to give you some caution that just the degree of stenosis in and of itself is not going to be always correlative to the degree of ischemia. And so obviously, when you can see the stenotic lesion of 50 to 70%, pre-test you would think that that may not be indicative of true pathophysiology, and in this one in particular, they had over 80%, where if the lesion was falling into that range, it did not have a positive FFR correlating with that. What was maybe the take-home message of this FAME trial in this particular sub-analysis was that when you look at the stenosis of 70 to 90%, which at pre-test you would still believe that many of those, or the vast majority, are going to have an FFR that is positive, there were over 20% that were still not having an FFR that would indicate pathophysiology, and that's even with the marker at 0.8. When you lower that down to 0.76, you're even increasing that number. So, but simply just looking at the CT angiography, whether it's invasive or by CT, is not always going to give you that correlation to knowing if that's a positive lesion or not. And this in and of itself is adult atherosclerotic coronary artery disease. Trying to extrapolate that to some of our own pathophysiology in pediatrics, where it's likely much more complex, it really just gives you caution on what the invasive testing, what the imaging is truly showing you. So in terms of MRI, this was a follow-up that was performed in circulation. In terms of MRI, adding to your predictive of cardiac events, they used several different criteria that you can gain by MRI, being one is an LV ejection fraction less than 50%, the evidence of delayed enhancement, which we heard earlier about in one of the previous talks, as well as abnormal perfusion. And obviously, if you had all three of those, it's kind of common sense that you're much more likely to have some sort of cardiac event, but you can see here just that quantitative stepwise increase, that when you have that additional information that you can gain by the MRI, the likelihood of having a significant coronary event is significantly increased. So in terms of our own institution, we primarily use either regadenoson or dobutamine, and I can go a little bit into the advantages of each of these, but we use those in select populations depending on what our hypothesis of the pathophysiology is like. Again, so if you think about what the pathophysiology of coronary artery disease, which is where we're taking all of our literature basis, this is obviously very different in terms of what we typically see in pediatrics. The atherosclerotic coronary artery disease is often abluminal. You may have some sort of fibrous cap that is to some degree stable or unstable, and you can see on the right there, as you have progressive stenosis, you're going to have worsening ischemia if you have that fibrous cap rupture and become unstable. That's what is going to lead you to a myocardial infarction. In pediatrics, obviously that kind of progression is not usually the case. When you look here at an arterial switch operation or a ROS, just from some of these CT images, you can see, in the top left image, that's a Yakub type D where the coronaries are coming retroaortic. You can see after the post-arterial switch operation on the far right where you have a right coronary artery that's being compressed. And then the bottom image there showing the left coronary artery having a very proximal stenosis as well. This is taken from some of our own patients. You can see here that measurement of the length of the left main coronary artery was not filling with contrast agent, which was obviously significant. I'll get into the specifics about that patient as well. In addition to just simply the anatomic components, this was a study that was performed about 15 years ago that was with nuclear med testing. And you can see that not only is there a difference in the anatomy, but particularly in the arterial switch operations, you have abnormalities just in the coronary flow reserve and in likely the vascular component. So it's not simply just anatomic to think of. Kawasaki disease, I heard that that's one of the pathophysiologies that's maybe most akin to adult coronary artery disease. And I would agree with that to some extent in some cases. You can see here in this bottom left, this is the coronary artery here. Obviously, in this case, there's giant aneurysms where you're concerned on either side of the aneurysm for perianeurysm stenosis. This is an image here just showing that artifact of the aneurysm formation. And then in this patient here, this is the same patient. This is actually a follow-up scan where they've now had thrombus formation. And I would propose that in these patients where you're having thrombus formation that may be unstable, that may be one of the more tougher pathophysiologies to predict the likelihood of events, just because I don't think that's going to have the same progression as you would with atherosclerotic coronary artery disease or simply just a fixed obstruction. And then lastly, as we've heard all morning, the pathophysiology of anomalous coronaries is likely multifactorial, whether that's from the osteomorphology, the intramural course, the interarterial course, where the origin is. This is likely all going into play, but we look at this as likely much more of a dynamic pathophysiology than just truly a fixed obstruction. And that's going to go into what pharmacologic stress agent we end up choosing. Likewise, as we heard from Dr. Rogers this morning, this is just some of our CT images of myocardial bridge, where again, it's likely much more of a dynamic pathophysiology. So this is just a slide that I saw that I oftentimes will show these conferences. I think outlines it very nicely of what our thinking is for what our pharmacologic choice is. When you look at the dynamic obstruction, we're typically using dobutamine. However, if we think that there's much more likely to be a fixed obstruction that's leading to the pathophysiology, we'll usually use a vasodilator, in this case, regadenoson. So just a very brief summary on adenosine, and regadenoson is a selective A2A agonist, or it's a selective adenosine agonist, but their mode of action is very similar. What you are doing is you are working typically downstream of the obstruction and essentially set up a flow differential. So if you have an obstruction in the LAD, adenosine is already a naturally occurring ubiquitous nucleoside that is acting already downstream to try to vasodilate and decrease the vascular resistance there. When you give regadenoson or adenosine, you're overwhelming that response and creating that flow differential. Now the rest of the coronary vasculature is seeing the significant increase in adenosine, and you have resultant hyperemia in those other areas, and then you have a flow differential. That's the physiology that is occurring when you give an adenosine agonist. In terms of the safety of adenosine and regadenoson, the one area that I would highlight as the advantage of regadenoson is because of its selective nature, you don't have nearly the same incidence of bronchospasm or AV block that you may with adenosine, just because it doesn't have nearly the same mechanism of action on all of the adenosine receptors. Within our own group, we had actually very good tolerability with the use of regadenoson. So in terms of our regadenoson experience, we've done 172 patients, 182 total stress examinations, so we have had some doubling up. The majority, as Dr. Paradon was describing today, outlines very nicely as far as what our typical lesions would be, which would be an arterial switch operation, the Kawasaki disease, or a Ross operation, and then I will get into our data as far as the anomalous coronary group. So we've done a total of 51 studies in the arterial switch operation. We've had a total of 16 perfusion defects. There is some doubling up of the same patients there, and I show you the heart rate and the systolic blood pressure change. I don't have the time to go into all of the details of the arterial switch patients, but I will say that many of these patients have either had perioperative complications, have had previous procedures due to concern for coronary ischemia, whether that's a perioperative lima or a bypass graft of some sort, or they have an abnormal coronary anatomy that makes them thought to be more prone to coronary ischemia, whether that's a Yacoub type B or type E, or in the case of the circumflex, a Yacoub type D, where that's wrapping retroaortic. In terms of our Kawasaki disease, again, as you would expect, the majority of these patients are found to have either large or giant aneurysm formation. And then the Ross operation, we have a lower incidence of perfusion defects in this population. And Athar, I think, will be talking after me a little bit about some of our FFR and cardiac catheterization correlation. So this is just a very brief slide, and again, some of these studies have already been outlined by Dr. Paradon as well, just showing the numerous trials that have looked at the arterial switch operation. The vast majority of these patients are indeed asymptomatic, so we've seen the issues with using that kind of data and fully extrapolating it. This is a very recent meta-analysis that looked at nearly 9,000 patients, and you can see down here when you add these up, it's just over 2% that have had some sort of diagnosis of coronary complications, interventions for coronary complications, or death. So looking a little bit closer at just some of our patient examples, this is a 2-month-old arterial switch operation that was performed at an outside hospital. We saw this patient at approximately 3 weeks post-operative, coming for an outpatient echo. And you can see here there's significant left ventricular dilation, poor function. Although it's just qualitative, those mitral valve papillary muscles certainly look somewhat echogenic. These are just some still frames, and again, this is that same patient that I took the image of before, where there's that proximal portion of the left main coronary artery is not filling with contrast, and you can see on this still image of the coronary fly-through the difference in the osteal morphology of that left main compared to the right. So the image on the left is just a resting short axis image, and the image on the right is our stress perfusion with regadenoson. We use just a weight-based approach. And just going through this, get this to play again. These areas of darkness, that's particularly up at the base, but in particular this mid-ventricular area, you can see that darkening rim, which was significant for hypoperfusion of pretty much the entire left main coronary distribution. Unfortunately, this patient was taken to the cath lab, but just due to the timing and the time course from the time we got this patient, we were unable to recanalize the left coronary artery, and they were discharged home on heart failure medical management. In looking at Kawasaki disease, and Cory did a great job outlining the utility of echo and the decision-making that goes into that. This is the AHA guidelines, where you can see that they break the coronary anatomy down just based off of aneurysm skies. and intraluminal length. Here was a recent JAMA article published out of Japan where they look at over 1,000 patients, and they break them into small, medium, and large, primarily based off of Z-scores of Japanese data, with the small being a Z-score of less than 5, medium actually being a Z-score of 5 to 10, or an intraluminal length of less than 8 millimeters, or large being greater than Z-score of 10, or an intraluminal length that was larger than 8 millimeters. And you can see here, just in the percentage, even these medium size coronary aneurysms still had a relatively low incidence of coronary events or MACE versus the large patients, which I was a little bit surprised about in thinking that we would have a larger incidence in that medium-sized population. This again, though, is Japanese patients with Japanese Z-scores, so you can't exactly extrapolate that entirely to the American literature. And then when you look at this Kaplan-Meier curve, this was just bearing some of that data out just in a visual that makes that a little bit easier to see. In terms of our own experience of Kawasaki disease, we've done a total of 45 patients. The majority would fall into either that large or giant coronary aneurysm population, and that's where we've seen the vast majority of our perfusion abnormalities. Many of these cases have either had cardiac cath for further assessment or potential intervention. And we can look at a couple of those patients as well. This is a 7-year-old. He was a late diagnosis of Kawasaki disease that was diagnosed in Mexico. He had giant aneurysm that was seen shortly after the diagnosis of all his coronary vasculature. He had a mural thrombus that was noted in a giant right coronary artery aneurysm, and he was presenting to us for further medical management. His echo demonstrated large coronary aneurysm of the RCA and the LAD. And in this perfusion here, again, you can see just this dark area of hypoperfusion in the subendocardium. With this wall motion assessment showing hypokinesis, which we performed during the coronary hyperemia after the perfusion assessment. So this patient was taken to the cath lab with the intent of intervening, but unfortunately his RCA and LAD were completely impassable, and so he has continued on with just medical management, and then he'll have serial examinations. This is a recent patient where we actually were able to do some intervention. This was a patient that had an undiagnosed arteriopathy. It had multiple cardiac catheterizations being done for the renal artery stenosis, and had moyamoya disease with a history of CVA. And you can see here on pre-intervention, in particular these areas of subendocardial hypoperfusion, and then post-intervention, that significant improvement in these same regions. We did not intervene on the circumflex, and that's the one area that still is showing a little bit of hypoperfusion there compared to the pre, but that's a drastically improved result after angioplasty of the right and the LAD. One more case is a 12-month-old tetralogy of Fallot patient that was repaired at an outside hospital at 7 months of age, and they presented to us at 3 months with some relatively nonspecific findings of fussiness and ventricular dysfunction. Here's a quick look at their CT showing this coronary that is significantly narrowed here with these arrows. And again, in this was a right dominant system, a left dominant system. You can see this area, particularly up at the basal region of hypoperfusion. While we were deciding, the patient actually had a cardiovascular collapse 2 days after the MRI and 1 day after the cardiac catheterization that confirmed this finding, and went for left coronary artery patch augmentation and has had return of biventricular function. Here's a look at the CT afterwards and is now on aspirin therapy. Just very briefly, our use of dobutamine, which is obviously a different mechanism of action than the regadenoson, and this is our choice in patients where we feel like the pathophysiology is to be much more of a dynamic nature, namely anomalous coronaries or the myocardial bridge patients. And this is going to work obviously very differently by increasing left ventricular contractility and myocardial oxygen demand. We do have a lower use just due to the side effect profile and patient tolerability. You can see obviously in this meta-analysis there's a higher likelihood of cardiac side effects. This is just a very quick look at seeing our stress MRI is part of our usual protocol for patients of our anomalous coronary group, both pre and then as well as if they do have an intervention post-testing. And so we've done, in the anomalous coronary group, we've had 133 patients. We've had limiting side effects in 14 of those. The vast majority have been nausea or vomiting. We have had 3 patients that we've had to prematurely stop due to hypertension. And you can see in the anomalous right, we've had 13 positives with 116 patients. In the anomalous left, 3 out of 17. I didn't show any cases from that because I know that we have some cases showing some of the MRI images that are going to be shown a little bit later tomorrow. So what we've learned, tolerability of regadenoson is excellent, and it's much better than the dobutamine. We really try to emphasize discernment over the pretest probability, knowing we can't fully extrapolate that data of the FAME trial. I am trying to really talk to my colleagues when they order a stress MRI to discuss what is the potential mechanism, because if we have a coronary CT that's not showing any significant narrowing, it's really going to take some convincing as to why we need to do a pharmacologic stress MRI. And then a reminder that really the stress MRI is just one piece of this clinical puzzle, and symptoms, whatever they're worth, and lots of other data does go into the decision making. These are just some of the areas where we need improvement. So in conclusion, CMR is an optimal non-invasive method for detection of myocardial perfusion deficits. We are trying to maintain a high pretest probability before performing this test, and different pharmacologic agents may be better suited to different types of pathophysiology. Thank you very much.